All right, recording has started. We're going to start where we finished on Friday. Talked a little bit about cirrhosis in the beginning stages of what we would see. If you have not looked at the PowerPoints before, you might be a little lost today, but we do hit the high points, I feel like, repeatedly with cirrhosis. One of the things that they can experience is portal systemic encephalopathy. And if you think about encephalopathy and what that is, it's a mental status change usually resulting from toxic chemicals in the brain. It can happen in cirrhosis, it can happen in a lot of conditions, but specifically this is from liver, okay? So if you have end-stage liver failure, if you think about how the liver works, what does the liver do, okay? It breaks down the many nutrients in your body, specifically protein. Protein is the number one thing that it breaks down or gives the bile to break down. If you cannot convert the ammonia that it releases to urea, have you ever heard of urea before in your urine? It's excreted in your urine. It's going to have that large amount of ammonia circulating in the body. Okay? So if you have a lot of ammonia in the body circulating around and it happens to get to the brain, what do you suppose is going to happen? It's going to make you very, delusional, potentially relating to a coma. There are 4 stages that the ammonia levels go through in the body. Usually the first stage, they're a little loopy, level of conscious changes. Stage 4 is coma, so it just gradually gets worse. You do not have to know the specific stages, just know that stage 4 is the worst, okay? And you get bad into a coma state, okay? Things that can contribute to the encephalopathy, obviously a high protein diet. If your liver cannot physically break down the protein, it's not good that you're just giving tons of protein. Because if it can't break it down, it's going to connect all that protein in the body, and that's going to cause worse ascites, worse end-stage liver failure. Some kind of side notes that potentially could make it worse. The first thing, obviously, is going to be the protein diet, but infections or hypovolemia, if you have hypovolemic shock, can definitely contribute to it. Electrolyte changes, specifically low potassium. Constipation, why do you think constipation contributes to it? How does protein, when it breaks down, where does it go? How does it get released? Out of your stool, right? Okay. If you think about how that medication lactulose, which we're going to talk about, works in the body, it excretes ammonia out through your stool. If you're constipated, it's not getting released. So if you're constipated, it'll keep it inside the body. GI bleed. Bleeding has a lot of protein in it, okay? If you've ever looked at the components of blood, protein is a big factor in blood. So if you're actually bleeding, specifically from varices, what we talked about this week or the past weekend, it can contribute to your coma as well, because that protein is circulating in the body or you're potentially bleeding. Okay? Drugs specifically, since you're already sedated or you're in a coma state, all the medications that cause more sedation is not going to be good for you. Okay? It's going to produce more effects and more sedation. Okay, what are we going to see with encephalopathy? Obviously, level of conscious changes. You're going to become more lethargic or more drowsy. Your thinking process might be combative. If you've ever had a patient with very high ammonia levels, you're going to see them be very aggressive. Okay? It's not their fault. It's not something they're baseline. They're not a mean person. It's definitely the ammonia levels. So once these ammonia levels start going down, you'll start seeing them become more alert and also more cooperative. Asterixis. We're going to look at a little video. What this is. Anyone watch The House of Cards? I don't know if you remember that. The part where he was flinching like this. That, and he goes, "What is that?" And that was Asterixis. If you're wondering what that was. So this is what you'll see with people with end-stage liver disease with encephalopathy. Okay? This is what they will do to test to see if they're in an advanced state.
This video will introduce you to asterixis, also known as the flapping tremor, and it's seen in various conditions such as cirrhosis, hepatic encephalopathy, opiate overdose, acute liver failure, and Wilson's disease. What you're going to want to have is your patient in front of you with their wrists extended, back like so. The physician will then take their hands and push back on the patient's hands, further extending them, and look for almost like a clonus type movement, an uncontrolled.
Obviously he doesn't have liver failure, so it's a little staged. So it's not going to be that like easy to do, but any tremoring of the hands is what you're going to see. Okay. So when you extend your arms and push the wrist back, You should see like a flicker at the tips of their finger. Okay?
Flapping tremor, which may be symmetric in both hands or asymmetric. You want to note how long this lasts, its amplitude, and its frequency in your note. Sometimes, in some patients, this tremor may exist simply when they extend their wrist without physician provocation, like this, and they won't be able to fully extend their wrists on one side or both. That is asterixis.
Okay, pretty basic. But just that tremor of the hands is a clear-cut sign that they're in the end stages of liver failure and they potentially have ammonia levels very high. Okay? Constructional apraxia, that's what they're going to do when they can't like button their shirts, they can't do the constructional, like occupational therapy duties, drawing objects, writing, their penmanship is poor because they can't actually get those connections through the brain and then through the actual constructional ability. Theater hepaticus, that's when they're going to have like a very foul-smelling breath, and that's dealing with the ammonia levels as well. The higher the ammonia, the stinkier their breath. It's like a sweet fecal odor. I know it sounds terrible to think about, but it's very true. When you go into these patients' room, they just reek of stool. One, because they're actually having stools because we're trying to get rid of the ammonia, but two, because their breath is really, really bad. Of course, yep. But they're so out of it that they probably don't really know what's going on. Usually these people are stupor to the point where you can't really arouse them. And yes, they could be intubated if it's that bad. Management, first and foremost, we need to reduce the ammonia levels. It's fairly easy to reduce ammonia levels because the way ammonia works is we excrete it through our stool. Usually your body breaks down protein and it converts that ammonia to urea out through your urine. Well, we can also go to our stool as well. Okay? So that's what we do mechanically with our medications. Serum ammonia levels, we do not have to know the specifics. I won't have you monitor or know exactly the same level of what you're supposed to know for a patient. Just know that high is bad, obviously, the high ammonia levels. We want to limit their physical ability or physical activity. Most patients, we encourage activity. But if you think about how physical activity works, when you're burning calories, it's letting off something called ammonia, and that can potentially increase the ammonia levels. So we do not want them running around, walking down to the hallway. We want them staying pretty stable in bed rest, okay, until their ammonia levels are back to normal. But I promise you, they will not be walking anyway because they're so out of it. Okay? Dietary limitations, obviously a lower amount of protein in the diet. What are some foods high in protein? Meats, of course. What's that? Eggs, peanut butter. These are things that you might see potentially on their diet trays coming up. Let's say their ammonia levels were high, but they're not to the point where they're unconscious. You will definitely have nutrition sometimes put things on there that they're not supposed to. So always monitor their trays. Fatty foods and simple carbs are okay. The liver does break those down, but proteins are harder to break down. Okay? That's why they say protein's good for your body. It's harder to break down. Keeps you fuller longer. Okay? So it's harder on the body. The two medications, you'll have to know both of these. Lactulose, you may or may not have heard of this medication. Talk briefly about what it does. It's going to take those ammonia levels, excrete them through the stool. It's also going to bring water in from the rest of your body. Okay? Definitely a high risk for hypovolemia because you're going to have frequent stools. Okay? What's another thing they might be at risk for? Think about electrolytes. Potassium. You may potentially have hypokalemia. So they will have their electrolytes monitored at least daily. If they're having 15, 16 stools a shift, I would say twice a day, and that's not uncommon for these patients. For dosages and how frequently you would see the dosages, I'm not too concerned about that. I'm not going to quiz over what's the specific dose. Just know that our desired effect is 2 to 3 stools a day. And you may laugh at that because 2 to 3 stools is an understatement for how much they probably will go to the bathroom. Most people, you'll see upskirts of 10 a day. That's pretty normal. Okay? We obviously don't want it to do that for too long. 1 or 2 days max is probably the highest amount we want to have them doing stools for that long because then they're going to start having problems with hypovolemia and electrolyte problems. Okay? Neomycin sulfate is an antibiotic, basically, a broad spectrum antibiotic. The normal flora inside your intestine that break down protein, it's going to basically kill that flora. So it's not necessarily good for your digestion and like bacteria in your bowels, but it's going to help so it doesn't break down more protein. Because then you're going to have even more problems with the ammonia levels. Okay? Specifically, you can give it PO, but it can be given as an enema as well. But PO will be your number one But think about a patient that's stupor. How are you going to give it? Okay? You're not going to give a PO solution to someone that can't physically protect their airway. So you might have to give an enema. Lactulose is probably going to be your number one that you use, right? The most common one you'd see with ammonia levels. The antibiotic is common if you're not getting any effects. The lactulose is first line. You'll see it first in the first couple days, and then you go on to the antibiotic to help with the flora. Okay? What else can we see with cirrhosis? Coagulation defects. What kind of things would you think about with the liver? It's helping with your nutrients, right? Your clotting factors. If the clotting factors are affected because of liver failure, you could potentially have bleeding, okay? What's another problem with liver that we think about? Remember the hepatic portal hypertension that can cause varices? They can bleed. So now we don't have clotting factors, and now we have pressure in those veins that could potentially rupture and bleed. So if you start bleeding, you may not be able to stop, okay? What medications are we going to give to people that you can't potentially stop bleeding? Vitamin K, and that's specifically one of the ones that the liver makes and synthesizes, and if you don't have that, you have to give it mechanically or through an injection. What's another medication? Well, not really med, but product we can give. Plasma, remember plasma, fresh frozen plasma, that can reverse bleeding. Specifically, if you're losing lots of blood, you should be getting plasma. Vitamin K is not enough if you lost more than a couple liters of blood, because you have to replace the actual blood components. Okay? People with this type of problem obviously would have easy bruising because they don't actually have the vitamin K to clot. If this does become problematic, we have to make sure we watch for hemorrhagic shock, because if they're bleeding, we could potentially have other problems with shock. Okay, the known causes of liver disease, we're going to talk about in general of cirrhosis, the overall picture. Alcohol is going to be your number one. Usually binge drinking. Just because you drink 1 or 2 drinks every day for 5 years doesn't necessarily mean you'll get cirrhosis. You might have someone that binge drinks once on the weekends, every single weekend, and gets cirrhosis. Okay? There's no clear-cut way. There's no way of saying, yep, it's because you drink all this time or specific amounts. But more repeated amounts of alcohol are going to cause cirrhosis. Hepatitis C and Hep B and D. Hep C is probably going to be your number one that causes cirrhosis, but B and D also have some components to contribute to cirrhosis as well. Drugs and toxins. This kind of relates back to Tara, what she was saying about her mom taking that medications that potentially cause cirrhosis. Toxic drugs that have to be filtered by your liver. Think of acetaminophen overdose. Okay, you could potentially get liver failure because of the medications that a doctor prescribed or that you abused it in some way. Okay. Biliary disease, remember that one's the obstruction. Think about our 3 types of cirrhosis. Biliary obstruction is when they can't actually get through the liver, and it can pool blood in there and potentially make it necrotic. Then you get to the autoimmune genetic disorders, things that there's nothing you did, it was just because your body was more prone to cirrhosis. Then you have the next one, cardiovascular disease. That's going to be more with the 3 types of cirrhosis. That's going to be a very high one. The right-sided heart failure. If you have right-sided heart failure, it's going to go back into your liver, and it's going to pool that blood in there. Men are definitely going to be affected way more than women. I think I've seen an upteen amount of men compared to women in the hospital with the ammonia levels that are high and liver failure. And that's not being sexist, it's just more common. Prevalence, 27,000 individuals die from cirrhosis each year. Doesn't seem like a lot, but it is. Usually, the more prone to alcoholism that you are, say in family genetic tendencies, your chances will go up. Okay? Regional does have a lot to do with it as well. Okay? Depends where you live, what are you surrounded with, what do we do as high schoolers in a small environment rather than a large city. Okay? A lot of younger kids get bored in smaller towns, so it is more prevalent in smaller areas. Okay? Okay? The early stages versus the late stages. You will have to know the difference on exam. What you're going to see later, obviously jaundice is something you would see with cirrhosis, but is it early stage or end stage? Okay? You have to know the difference. With early stages, it's very generic. You may not even think you have cirrhosis. Cirrhosis might be very, I don't know, I guess it's not very specific on what your symptoms are. You would have a lot of these symptoms and not think one thing about it. Okay? So you may not even go to the hospital or the doctor until you are potentially end stage. But fatigue, general fatigue is pretty common. They get more tired over time. Weight changes, they usually lose weight unless they're getting ascites, and then they'll gain weight, but that's usually late stage. GI symptoms, they'll stop eating, that will make them lose weight. They get really nauseous. These people will be on lots of Zofran or potential medications for nausea medicine. Abdominal pain and tenderness, that can deal directly with the liver enlarging. It hurts when your liver is enlarging from potentially those nodules. And then itching, that's with the dry skin as well. Your bile salts are accumulating on the skin, and if you think about your ascites getting bigger, you get really dry, okay? So we don't want to use harsh soaps, no alcohol in that area, because it will contribute to itching, and then they'll break open their skin, and it gets really tight. Late stages, this is probably what we talked more about on Friday, and what you'll see is very common in patients with cirrhosis. Jaundice or the icterus, the yellow eyes that you see. Icterus is going to be something you see not necessarily early in the process, but you'll see icterus before you see a lot of yellow on the skin. Okay? Dry skin and rashes, very common. Bleeding, why do they have bleeding? Cirrhosis. Right, your clotting factors are poor, and also you could potentially have those varices, right? Your dilated veins all throughout your body. You could have hemorrhoids, varices, and any other vein inside your stomach could be affected. Spider angiomas and pulmonary erythema, we talked briefly about that on Friday. It deals with the bleeding factors as well. Ascites, how are we going to measure that? Tape measure, we're going to do an abdominal girth to make sure it's not getting bigger. Most nurses won't do that. They'll do it on assessment, like right when they come into the hospital, and they might do it every shift, but not like every time they go in for an assessment. Okay, it wouldn't be every 4 hours. You would notice throughout the day if it was getting bigger or smaller, but when you first come on the shift, you should get a general assessment of how big it is. Okay, and then they can get the edema, and do you remember why? Remember that protein, albumin? If they're experiencing it all into their central section, they potentially might have a serum albumin that's lower, okay? And that can cause third spacing and edema. Just a slide that kind of shows all the things you see as cirrhosis. This is actually a really good slide whenever you're studying and you've already done your studying to go through and see if you know all the symptoms you'd have with cirrhosis. Okay, so it comes back to our ascites, we talked about over here. Abdominal girth, obviously their belly's going to be enlarged. What kind of things will you see on their stomach? You can see stretch marks, but also remember that caput medusa? Remember what that was? Obviously besides reading it. But your veins are so distended in your stomach that it can cause almost like varicosity veins inside your stomach. They're thick and they're elevated. You'll see it right away on assessment. Okay. What is orthopnea? Obviously, you know it's something to do with breathing, but what's it mean specifically? When you lay flat, right, you can't breathe. Why do you think you can't breathe? Right, it's going to push up on your breathing. So we don't want to lie these people completely flat, potentially just to, briefly, just to weigh them or potentially to measure their girth, but we would not lay them in bed like this for long periods of time. Most would probably be a minute, okay? If it's extreme amount of ascites, they will have respiratory distress, okay? Think about after a large meal, when you lay down, you just feel miserable. They feel even worse because there's 10 pounds, 30 pounds, potentially of fluid on their belly. Okay. Let's see here. There's no clear-cut way to actually know what's normal for that patient. You just have to ask. I always say, is this normal that your belly looks this big? Maybe it's always that size. Okay. There are some gentlemen that probably have, or pregnant women that have bellies like this, so we have to get a general assessment. Okay. Just because they're 50 centimeters doesn't mean that that's new or abnormal for them. You have to ask. Okay? Percussion and palpation. We have to actually find that liver. Okay? The way we find the liver is we percuss. You guys weren't really taught that in your general assessment for percussion, but the way you do that is you take your finger, and remember you do this. Have you ever seen those before? Where you see where the hardness is at? Well, the liver will have a very dull sound to it. Your belly will be hollow, especially if there's ascites in it. They'll sound like something underwater almost. So you're doing the percussion, and once you get to the liver, it almost sounds like like you're knocking on the door, like that, instead of it's like more like going through water instead of on the door. I don't know if that makes sense. Like the dullness. If you can actually understand what I'm talking about. But when you're going through, you know where the liver's at because of the dullness. Okay? Kind of like over a bone. It's hard. same thing, it's prominent. Palpating, you've seen probably doctors go in and they really dig for the liver. I've seen that quite a bit when they have high ammonia levels. They're looking to see if it's enlarged, okay? Most people, you can't really feel it unless you're very thin. If you're really large, you may not be able to dig that deep and find it. But thinner people, for sure, you can find it easier. It's right underneath this rib, so if you're looking for it. We had to do all that in assessment for our bachelor's. Like, we had to make sure we found everyone's liver. And that was really hard, because you could feel it. You can feel the edges in there. But I felt like you were digging really hard. I couldn't find mine now. But yeah, you can find it on most people. Other things that you can do, these people are going to be very nauseous. So they might have an NG tube down anyway to prevent their nausea from happening. Remember I told you about the varices? You have to be really careful putting an NG tube down because you could rupture one of those varices. Sometimes physicians or like surgeons will come in and they'll put the NG in, guided by like an ultrasound or guided by some type of picture, so they can see if it ruptured. You'll know right away if you ruptured a varice. It'll be bleeding. Okay? Things you can look for stool, they're going to have very dark stools if it's a higher bleed. If it's very frank red blood, you can assume it's hemorrhoids or a lower GI bleed. Okay? But most of these people will have the melena, which is dark, very, very dark stool. We talked about the feeder hepaticus. There can be sex changes in men and women. They can actually lose their periods or potentially become infertile. Men can have gynecomastia. That's where they enlarge breasts. That deals a lot with their hormones. They can potentially have impotence as well. The bruising petechiae and enlarged spleen has a lot to do with your platelets. Remember how we have distended veins that go back into your spleen? And the spleen becomes really large. And it houses all those platelets. Okay? The platelets stay there, and since they're not moving, they potentially die over time. So you'll see the platelets start to decline, and you'll see more bruising, bleeding. And the more they bleed, the more the hemoglobin hematocrit drop, right, if they actually have signs of bleeding. Neuro changes, if they are having level of conscious changes, usually it's a later stage if they're starting to have the level of conscious change because of ammonia levels, right? If your liver failure is actually intact, they're actually occurring. Liver changes, our liver will actually cause the neurological change to happen later in the process, okay? So if you're at this stage, it's priority far gone. And then the asterixis, that's the other symptom we just looked at the video. Okay. Psychosocial, a lot of this has a lot to do with guilt. They know a lot of the problems with cirrhosis comes from alcoholism. So we really have to talk to our patients. They're going to start feeling like it's their fault, which I'm not pointing fingers at this time, but it was a choice they made to drink. Everybody knows drinking is bad in large amounts, but we would never say, man, if you weren't to drink, you wouldn't have this problem. That's not going to help the situation. We already have the problem. Let's deal with it now and teach them about ways that they can help themselves and prevent more problems. Okay, this is not a time to judge. You're going to have patients that come into the hospital, and they're going to be alcoholics, and they're going to come in, and you're going to say, why should I have to deal with this? They're the one that did this to themselves. Well, that's 95% of your patients. Okay, a lot of your patients did things they weren't supposed to do, and they end up here for that reason. But that's why you're a nurse. Take care of those people anyway. But these people do have a lot of psychosocial issues and also finance issues. Alcohol costs a lot. If you're an alcoholic, these people are drinking a fifth of whiskey, potentially a case of beer a day. How expensive is that? A lot. Okay? And I'm going to guess if they're drinking that much alcohol, they can't work, or they shouldn't be working. Okay? Not to mention if they've had DUIs, child custody issues, who knows? I'm just saying that. On top of that, there's a lot of financial issues. And then we might potentially give them medicine that they can't afford. Okay, so we have to think about the whole picture. These people are going to require a lot of social services. Okay? All right, liver enzymes that you might potentially see. I know you have seen these enzymes, but you probably didn't know what the heck they were. Okay? AST and ALT. Have you had patients that have had these? Really drawn to see. Most people's are normal, unless they do have liver failure. AST and ALT are going to be your measurements of specific liver function. That is the best test that you can get for the liver. Okay? LDH is another enzyme secreted by the liver for digestion. If it is elevated, it's showing that it's stressed or there's an inflammation, and it can't actually digest those nutrients. ELK-Phos or alkaline phosphate, Very seldom do you see this lab done. But when you do see it, you suspect obstruction. What kind of things would you see with obstruction? Gallstones. Some say that? Yep, gallstones. If you suspect gallstones, you better believe it, and out quads will be drawn. Okay? A doctor would be silly not to do that drug. Why would you just go in and explore something if you didn't know a baseline? Okay? So your L quad, if that is elevated, you can suspect obstruction. What's something else that's not invasive that you could do for an obstruction? Not surgery. Ultrasound. Yep, they do an ultrasound of the liver over here, and then that way they can see if there's any stones or obstruction. Okay? Elevated bilirubin levels, that deals with our jaundice. Bilirubin is excreted in the stool. If you think about the color of your stool, it's normal is brown. That is bilirubin broke down. Okay? Let's say your bilirubin is not being broke down properly because of obstruction. What color stool are you going to see? Clay. Clay or white. If you see clay or white stool, be concerned. Babies, don't get as concerned because liver is actually one of those things that don't mature as fast as other organs. So they might have some clay-colored stool in the beginning, but that is normal for a baby. So it's not as abnormal for them. If it prolongs or stays like that for weeks, then yes, it's concerning. But I remember seeing a stool of a baby once and it was white, like completely white. I was like, what is wrong with this kid? But it's very, very normal. Okay. Right, so the bilirubin is broken down, excreted through the stool. If for some reason your bilirubin is really high, it can be spilled off into your urine, and your urobilirubin will be high as well. Continued labs. If you notice for the test coming up, there's a lot of diagnostics. It's important that you know all of them because it's going to contribute to the big picture. Okay? A lot of them aren't directly related to liver. It's what the liver failure does and produces other things like low platelets. Okay? But that is important for the exam. Fecal urobilinogen, I can't say it, is when you have obstructive cirrhosis, and that's when you can't actually break down that bilirubin, and you will produce those clay-colored stools. Why is your serum protein low? Remember we talked about this on Friday? Ascites, okay? So when your ascites is in the belly, you're pulling all that protein into that third space, which is your stomach, and all your serum protein, your peripherals, like your circulation, you will not have any protein or it's low in those parts of the body. Albumin is a type of protein, so you will have low albumin levels, primarily due to the synthesis of the liver. That's where it's made and broke down. When you have a loss of protein, this is not just with liver failure. When you have patients that don't eat and they're not having good nutrition, you'll see them get swollen. They get that third spacing edema. It's because of low protein. Okay? Clotting factors are your bleeding studies, your PT, INR. You'll still see those be elongated because they can't actually clot. And you'll see people have a higher incidence of bleeding, which can contribute to your varices. Platelets will be low. That's dealing a lot with your splenomegaly. It's trapping those platelets. It can't actually circulate the platelets in the body. So you will see those drop. And because of the platelets being low, you'll see bleeding. Okay? So that's why your hemoglobin and hematocrit drop. Your hemoglobin and hematocrit do not just drop because of liver failure. It's because of the platelets. Okay? Your platelets are really low, and you get hit in the arm, you're potentially going to bruise and bleed. Okay? And that can cause hemorrhage if it's specifically in your stomach, your head, wherever you may have that trauma. Okay? Your white blood cell count can be low. It's not diagnostic of liver failure, though. That is shown over time that you do have lower white blood cells. Ammonia levels will be high. We talked about that. Creatinine can be high only because once your liver fails, other organs fail. Okay? So usually liver fails, and then your renal system will fail because of your liver. And that's how you know if it's really bad, because your other kidneys are shutting, or your other organs are shutting down. Okay? Since you have tons of fluid in that belly, you can have dilutional hyponatremia. Remember we talked about them having the aldosterone system triggered, and that can cause high sodium and retention of water. Most of the time you have hypernatremia, but let's say you get 20 pounds of fluid on, you can have some dilutional hyponatremia. Okay? They're not truly low, but their water so much in their body is diluting it out. Okay, so what are we going to do to find the cirrhosis or find the problem? First line is X-ray. It's the easiest and it's the least invasive. We're not going to start with an angiography because we want to make sure that we're not potentially hurting anything and making them in more pain. Ultrasound can definitely be done. It's the outside of the body. It's pretty easy. Doesn't take much time. Probably takes 20 minutes. They look for obstruction, specifically gallstones, okay, and biliary cirrhosis. Upper GI series. This is an X-ray with a contrast. This is not a CT scan. The X-ray will be done primarily in the upper part of your GI system, not necessarily your lower part. It's a specific picture in one area. So they will swallow contrast into this mouth, and it'll light everything up like a Christmas tree. It takes time, obviously, for you to digest that contrast. That's why they only do the upper part, because it would take 24 hours for it to get down to your actual stool area, or your large colon. Okay? Angiography, this is what they do when you're actually bleeding. Let's say you have the varices. They'll go into those veins and look at those to make sure that there's a way they can actually light it up and look at it better, and then they can fix it as well. CT scan, that's another one that you can do, similar to the upper GI series, but you'll have an IV contrast instead of the GI contrast. EGD, this will probably be the most common one you see with the invasive part. You're not going to have open surgery of your liver. You're not going to open that up so you can see it. But with an EGD, they go down with the scope. Have you ever seen people with EGDs? Okay. They go down with the scope and they do some exploratory to see where the varices is at or the potential bleed. Okay. They can take biopsies and they can do, and I can't think of what it's called right now. They do an EGD, but they go further into their bile ducts. Oh, it's going to bug me now what that's called. But instead of going and stopping here, they stop at the liver. Okay, they go through the liver, through those veins, and they can get way down in there, and they can see if there's bile duct obstruction. Okay, they have to go to Sioux Falls for that. I know that because I have many patients that have to go for that. It's gonna bug me now. After, it's usually a local anesthetic. They don't usually get intubated for EGD. You usually just get a Versed or sedation or some type of small amount just to kind of keep them comfortable. They will not get enough to make them completely out, okay? Unless they're bleeding, hemorrhaging out of their mouth and they can't actually breathe. Okay? After surgery, we want to make sure they have a gag reflex returned, because if they don't and we produce water or put something down there, it can cause them to aspirate. Another diagnostic test is a radioisotope liver scan. This is when they put those radioisotopes inside the body and it lights them up like a Christmas tree. And it can actually show exactly what the liver is doing and shows the progression of cirrhosis, the thickening of that liver. The clear-cut way to know for sure if it's cirrhosis, you can do all those signs or all those diagnostics. It can tell you maybe what's going on. It sees something, sees the nodules, potentially cancer, but you have to get a biopsy to confirm cirrhosis. Okay? All those other ones are obsolete unless you do a biopsy. Biopsy is pretty invasive. Okay? That's why we wait last for it. And we obviously don't tell our patients that they have liver cancer or cirrhosis until we have this test done. Okay? Because sometimes they're shadowing or something that we can't physically see, and we don't want to scare the patient if it's not worth it. Okay? So the way a CT scan is done is they will potentially lay on their back. Usually this is done in the OR. It's usually not a bedside thing. And what they do is they put their right hand over their head. Obviously the liver's right here. And they're going to go in with like a needle and scrape off the part of the liver. It's just a small little piece. And they'll have to lay on their right side for a good 2 to 3 hours or 1 to 2 hours after surgery because they have a very high risk for bleeding. Okay? You just scraped a very vascular organ, and so that could potentially make them hemorrhage. So they put some pressure on that area to make sure they don't bleed. Okay? Once they go home, we encourage no blood thinners, no NSAIDs, things that would potentially make them bleed. And we usually tell them not to do too much activity for that first day. But it is pretty routine. It will be done as an outpatient. It just won't be done at the bedside in the hospital. And this is what it kind of looks like here. They do like a little piece that just gets cut off with the needle. Okay, and they take that, and then that's where they'll see if there's the hepatocytes that are being broken down or their cirrhosis problems. The liver's huge. I think it is our biggest. Yeah, it's bigger than all of our internal organs. Obviously, skin is our biggest organ, but liver I think is, I want to say it's 5 pounds. It's large, really big. I don't think this is going to work, but we can go through questions. A malnourished client with a history of cirrhosis is admitted to the hospital with nausea, ascites, and GI bleeding. The nurse recognizes that the ascites is the result of the lack of adequate what? Obviously, we don't have clickers, but D? Why is D correct? Remember, our plasma protein has a lot to do with our ascites. If you accumulate it all inside your stomach, your serum protein will be low. Which statement by the client with cirrhosis indicates that further instruction is needed about the disease? So which one is wrong, basically, right? Or the correct answer. So we know D is wrong, so the other three must be correct. Liver cannot regenerate from cirrhosis. But let's say you had a trauma where, let's say you got stabbed with a knife and it cut like, let's say an eighth of your liver off. There is potential that your liver can regenerate when you have a healthy liver, okay? Someone like you and I that does not have liver failure, does not have cirrhosis. But if it is for cirrhosis, it's not going to regenerate, it's not going to heal over time, it will progress and it's irreversible, okay? It may take 20, 30 years for it to degenerate, but it does get worse over time, okay? How does the home care nurse best modify the home environment to manage the side effects of lactulose? I don't really like the word side effect for lactulose because I feel like the indication or like what you suspect would happen for lactulose is what the answer is for this. But I've noticed a lot of like NCLEX questions will say side effect. When I think of side effect, I think of something that the med is not supposed to do, and it causes things that aren't supposed to happen. But with this, they're calling this a side effect, and I don't think it's meant to be. Right. What are you going to have these patients do a lot? Poop. Okay? So you would want them to have a bedside commode next to their bed or potentially next to their chair because they're not going to be able to make it. It is explosive diarrhea. Not kidding. It's very, very quick. They don't have time to get to the bathroom. But yeah, to me, that's not really a side effect. It's a indication or what the medication does. Okay, this is a select all that apply. I'm caring for a client with latent cirrhosis. Which one is that one? Alcohol, directly related to your alcohol cirrhosis. Which of these does the nurse expect to find on assessment? Notice I don't say anything about staging. I don't say early or late stage, okay? So then all the symptoms and side effects that you would see with cirrhosis can apply. And if I specifically say early or late, I specifically want those answers, okay? Any ideas? Is A right? Okay, that's to do with our bleeding studies, right? You have a high risk for bleed. B, what is icterus? Yellow eyes, that can happen, right, in cirrhosis. C, what's a swollen abdomen mean? Ascites. Okay, what about D? You don't know, do you? We haven't talked about that. Not right, it's there to distract you. Okay, E, what is current jelly stools? They look like shiny. They're really shiny and dark, okay? It's not melena. Melena is that dark stool that can be from bleeding. Current jelly stools are from something called interception. Okay. When your stool basically, think about your colon, it goes into each other. If you have like the actual colon, it pushes back into each other and it causes those stools. This is not, if you see anything with current jelly stool, it's relating to that interception, which we don't talk about it with this unit. But just saying that that's, you see that on the NCLEX question, that's what that's referring to. Elevated amylase level. What is amylase? Is amylase a liver enzyme? Pancreatic. You saw AM, so you thought maybe ammonia, maybe? I don't know. But that was a trick question. That's with pancreatitis. Okay, so not liver. ALT and AST are not amylase. The nurse is caring for clients in the outpatient clinic. Which of these phone calls should the nurse return first? Hard one. Can somebody have a history of esophageal varices and not be bleeding? Yes. Okay. If they were bleeding or having really frequent bloody emesis, they would trump number 2. Okay. But since they just have a history in right upper quadrant pain, which can indicate a varice potentially rupturing, but what does B indicate? Infection. And they also, if you think what that word is called, it's called spontaneous bacterial peritonitis. That's what I'm looking for on here. That is a very severe bacterial infection with ascites. If that stays in their body for too long, they can get septic and die. Okay, they have a high risk for hypovolemic shock and septic shock. It is B. D would be your next person to call because you'd suspect maybe, okay, they might be bleeding, but if they were truly bleeding, they would tell me, I've been puking up red blood. Okay, and they would probably tell you that. Number B, spontaneous bacterial peritonitis. It's the one Friday we talked about with the ascites fluid. When you do a pericard or paracentesis, you take that fluid out, you culture it, and you look for that type of infection. You remember it's a gram-negative rod infection, and you only have one antibiotic. I think it's Robaxin. Correctly. There's one antibiotic that specifically does that infection, and that's on that slide. All right, a client is admitted to the hospital for acute gastritis and ascites secondary to alcoholism and cirrhosis. It is important for the nurse to assess this client routinely for what? Well, gastritis, pretty easy, inflammation of the bowel, right? Something's going on with the bowel. And ascites, secondary to alcoholism. If you think about what ascites is, think about the pathophys. Why are you getting ascites? Not the serum protein. I'm talking about what can cause the protein, or specifically the hepatic hypertension. Remember that portal vein? Portal vein? It can cause hypertension, making all your veins dilated, okay? And that can cause your ascites to dump into your belly, okay? So if you're thinking about that, they could potentially have varices, right? Or they could potentially have hemorrhoids, something to make them bleed. So we look for blood in the stool, okay? If you ever see blood in the stool, whether it's dark or light, if you see a really black stool, don't flush it. Make sure you at least show the doctor or at least let them know that you saw it, or test it with a hemocult. You guys ever done a hemocult before? Where you dip a little stick in there and it says, yes, there's blood? Because some people are on iron supplements and they can have black stools. It's like a black and green stool, and that's okay. It's meant to be like that. But if you miss that, that can be the first sign of a GI bleed, and you can get ahead of it before they go into shock, okay? And so those are things you can look for. Blood in the stool is always bad. You never want blood in the stool. If I put frank red blood in the stool because they have a history of hemorrhoids, not as controversial, okay? A lot of people have that. But if it's dark, you better be doing something about it. The nurse places scissors at the bedside for a client who has a Blakemore Sengstaken tube. Select the most important rationale for this intervention. Please call Blakemore. Why would you put scissors at the bedside? Let everyone get the chance to read it before you shout it out. Any ideas? First of all, what is a Blakemore tube? What's it for? right? Esophageal varices, and what that does is for people that weren't here on Friday, it's kind of like an NG tube. It goes down your esophagus, and then here's your stomach. What it does is they put this tube down there, and there's this little balloon that gets inflated, okay? And it's going to push specifically on the varice that is causing it, okay? Whatever varice is bleeding, that's where they inflate it at. If for some reason this migrates up, it's coming out, here are our lungs, it could potentially cut off your trachea, right? If its esophagus is right next to your trachea, that balloon can push. If it's too inflated, here's your trachea. It can push into your trachea and cause you to go into respiratory distress, okay? What that little tube, when you're going down, it's full of air. You cut it with the scissors, all the air comes out, okay? So you have to have a scissors at the bedside because there's specific things like syringes that help you pull out the air, but that takes time. The cut will deflate in seconds, okay? The pulling out of air might take 20 to 30 seconds, which I know isn't that much longer, but a cut will completely kill it, okay? And that could potentially cause airway respiratory problems. All right, let's take a quick break before we start hepatitis.
So was it C or D? Because you can't cut, like B, you can't cut the balloon tube, right?
It says in the event upward displacement of the balloon has occurred, the scissors are used to cut the balloon and remove the air. I guess that should be worded a little differently. Yeah, you would cut the tube. You cut the actual tube. So it's like I said, it's probably not going to be worded like that on the test, but I'll make sure it's specific. C was in the event the tube has migrated, the scissors are to cut the tube in half. The reason why that one's wrong is because it's to cut in half. That's really why. But usually we're looking for upward displacement. All right, take a quick break and then we'll come back and start hepatitis. You guys are almost there, you guys. Spring break is 4 days. All right, let's get restarted here. I want to get through as much as we can. Okay, we'll do our best to get through the rest of this, but I have a feeling we're not going to. I will record the rest of what I don't get through, and then, like I said, the next PowerPoint will be up. I'm going to hope by Thursday that it'll be on TigerNet, because I don't want to do it when I'm on spring break either. I'm just like you, I need a break, and so I'm hoping to get that up. But if you don't look at it, I'm not going to hold anyone to it. It's not the end of the world, okay? I expect you to take a full break during spring break, okay? But some of you are ambitious little people and love to look at stuff ahead of time. Okay, so we talked about cirrhosis. That's our first problem, and think of all the interventions we did for cirrhosis. There's a lot with cirrhosis. That's going to be a majority of our exam and our upcoming unit test. Hepatitis is our second problem. Okay, guys, quiet down. Our hepatitis is going to be our next problem that you're going to see. There are many types of hepatitis. I know a lot of you have seen some of these in practice or have gotten vaccines to some of them. There are 5 types. There is hepatitis G. That's uncommon to the point I've never even heard of it or seen it. But there is something called hepatitis G. But you will not have to know that for the exam. The 5, 1 through 5, you have to know exactly what they are, what you see on presentation, how to fix them, and how to diagnose them. Okay? So they're going to be pretty extensive. Okay? So what is hepatitis? After the liver has been exposed to one of the hepatitis viruses, you will usually experience an enlarged or inflammatory state of your liver. And that's usually how they diagnose it as well. They actually look at the liver and how big it is. Potentially, fluid will result in right upper quadrant pain. They'll have a ton of pain with hepatitis when they initially get infected, okay, and a lot of discomfort. As it progresses, you will have a lot of edema in the liver, potentially obstruction, and they will experience jaundice. They usually go through 3 stages, okay, and those 3 stages are pre-icteric, the icteric stage, and post-icteric, okay. What is icteric? Remember the yellowness, color? Pretty self-explanatory. Pre-icteric is when you get first diagnosed, and it's when those symptoms first start, okay? Just because you get, for some reason you had a needle stick, you may be 2 or 3 weeks before you even get symptoms, okay? It might even be 4 months. Just depends on what the incubation period is. Incubation period is the time when you get the virus in your body to the time when you get symptoms, okay? So just because you have the virus doesn't mean you have the actual symptoms. Kind of like HIV. Just because you have HIV doesn't mean you have symptoms of it yet, okay? Icteric stage usually lasts around a month, and that's when you actually will have your jaundice. It's the state of when you're the most contagious. And then post-icteric is the recovery phase. which can take up to 4 to 6 months, depending on the type of hepatitis. Okay? So you can have this virus for quite some time. Most of these viruses are able to get rid of them over time or go away. Okay? Hep C is the only one that is very, very difficult to get rid of. And you will notice that in the hospital. Most people that have Hep C for the rest of their lives. But Hep A, B, D, and E are able to get rid of. Put a big star on this slide because I feel like this is the easiest slide to look at, and this is basically everything you need to know about all the viruses, okay, for Hep A through E. If you think about A and E, they're very similar in how they're transmission. If you think about the vowel, A and E are the only ones through A through E that have a vowel, okay? So a vowel comes from the vowel. Pretty easy to remember, okay? And it's going to help you on the exam. With vaccines, there is a virus that you can give for antibodies, and I'm sure you've gotten the Hep A virus or the Hep A vaccine before. Most of you, I think, need it for college. Am I mistaken? Okay. Hep B series is optional, except for nursing students. I think we all need Hep B series, right? I think I had to have it in nursing school. Potentially, there is a Hep C Hep C antibody vaccine is being studied right now, but there's not anything concurrent with research to actually give it to anyone. It's not FDA approved, but they are working on it, which is great for the prevention of Hep C because it's very common. For B, body fluids, this is how it's transmitted, blood, semen, and saliva. When you see that saliva there, think of not necessarily kissing somebody, but let's say you were bit by someone with Hep B. That's more a transmission. Okay, kind of like AIDS. You could get HIV from kissing someone if they had certain chemical or certain things in their body or their blood in their teeth or something like that. But usually you cannot get Hep B from kissing someone. It's only if you got bitten by someone in the hospital, which it does happen. Okay, so you could get Hep B from someone from biting you, but not kissing you. That makes sense?
What if somebody bit you and you punched them?
In the hospital, I've actually asked that question before because I said, can you do self-defense as a nurse? And they said, you actually can't. You have to protect yourself in the environment and leave the environment. You want to slap them back because it's a reflex. You can't do that. I've had times where someone will grab me like this, and I'll grab them and say, you do not touch me. I'll say I'll put them down, but I don't hurt them. I just protect myself to get away. Because I have to actually get their hand off of my wrist to move. But that's protecting myself.
What if you accidentally punch?
But if someone punches you, you don't just say, oh, I'm punching you back.
Everyone's automatic response.
Because I had a girl, she worked on a psych ward for a summer for her practicum, and she got attacked by a lady that was 250, and she got on the ground and started pulling her hair out, chunks of her hair were coming out, and she just got in the fetal position and protected her face because she didn't want to get punched. But I was like, oh man, I would have had a lot of resistance not to punch her back. Because you almost want to protect yourself just from getting away, pushing out of the way, but you can't do that. No matter how much they're hurting you, you have to get help, unless you're in an alley or something that you couldn't protect yourself. But most people will be around to help them get off of you. But I have had times where someone spit in my face, and I want to spit back in their face so badly. And it's gross, but it just got on my forehead.
I had an Alzheimer's patient bite me, and she bit me, and she had dentures, so I just popped out her denture.
Yeah. Or you'll have people too, that's why you never, when you're doing their strengths, you always do 2 fingers. You would never do all your fingers. Some people might grab and not let go. Or when we're doing lab draw for someone that's really needs to be restrained, we actually restrain them, and I sit on them basically. I've sat on people's legs and arms to make sure they can get lab draw. So you just do the best you can. It's for their own good. You want to help them. It's not because we're hurting them. But you can't physically slap them or spit back in their face. You will get fired faster than you can think about. Because that's a liability issue. Because then families will see you that punched them, not them that they punched you. Okay, continuing on. That was kind of sidetracked. Hep C, there is no vaccine yet, but I have a feeling in the near future we might get something on that regard. Hep C is by blood and semen. So you think of a lot of needle pokes in the hospital. They go down and they test for all the hepatitis and HIV. That's what they do when you get a needle stick in the hospital. Some of these you can give antibodies to the people, and that can help prevent getting the transmission. I believe it's A and B, if I can remember right. A and B, and you can get those antibodies, and what they'll do is help hopefully not get the actual virus because the antibodies are present. Okay. Hep D, there is no vaccine noted, but usually if you've had Hep B, you have Hep D. They're hand in hand, very similar viruses, and usually if you have one, you have the other. Okay. Signs and symptoms for all. This is the wonderful thing. You don't have to distinguish between every symptom. Okay, they all have very similar symptoms. On the exam, I'm just going to ask in general, what signs and symptoms do you have in hepatitis? Not Hep A, Hep C, Hep D. Okay, that's a nice one. The first and foremost, what they'll experience first is that right upper quadrant pain. It'll be very painful and uncomfortable in that area. They'll be nauseous and vomiting. They have a hard time eating. A lot of these people lose a lot of weight, and they potentially have it almost seems like the flu. So if you were to have flu symptoms, would you think, oh, I probably have Hep A? No, I won't. So that's why a lot of this goes unnoticed, and usually that's why Hep C people become chronic because they don't get it taken care of in the beginning. There isn't many interventions for hepatitis. They usually require rest, hydration, and nutrition. That's usually all they do for hepatitis. There is a couple medications though. Diagnosis, we are specifically going to draw a lab test, and that'll tell us exactly what's in the body, and it'll tell us which hepatitis they have. Okay, so we'll have those surface antigens. Okay, so what we need to know for all the 5 types of hepatitis is how they're transmitted. I want to know exactly how they are. For the exam, I'm going to ask you specifics. Hep A is transmitted how, or give you examples. Manner of onset, how fast are they becoming infected, and what are their symptoms initially? Like I said, a lot of them have the same symptoms. So you don't have to know specifics for that. Incubation periods, do you remember what that was from me telling you? Time you get a virus to the time you get symptoms. Just because you get infected on a Saturday night from having sex with someone with Hep C doesn't mean you'll have symptoms on Monday morning. Okay? You probably would have it 2 to 6 weeks later, depending on the virus's incubation period. Okay? Enteral forms, A&E, you get it through fecal or oral. If you think about going to a different country, remember how we drink their water? You're not supposed to do that. That's how you can get Hep A and Hep E. Okay? That's why they encourage you to drink bottled water, because then there potentially might be fecal matter inside their water, and you would drink that. Okay? Parenteral is B, C, and D. That's going to be specifically through the veins or the seminal fluid. Okay? Vaccines are only for A and B. You will not have any for C, D, or E. You got to make sure on exam you know exactly which one has vaccine. Okay? Vaccine for type C, we talked briefly about. There's current research. I have a feeling sometime in the future, but I wouldn't expect it near future. Okay. Like I said, symptoms for Hep A are going to be very similar to a GI upset or a flu, and so you're going to have very similar for all of them, but specifically for A, GI symptoms. It often goes unrecognized who would go to the doctor for GI upset or GI symptoms. It is not life-threatening. 90%, or I'd say 99% of people live just fine with Hep A and they get rid of it. Okay. There are some more severe cases in the elderly, and then over time, if you have a repeated exposure, you might potentially have more problems. The best thing is prevention. Getting the Hep A virus vaccine is the best thing you can do, and hopefully preventing Hep A from occurring. Most of you, I would say all of you, probably will never get Hep A because you've had the vaccine. Okay. Modes of transmission, so if you think about the fecal-oral route, this is when we go to different countries, you can drink their water, swimming in certain types of water that might have that fecal matter in there, or the Hep A virus. Specific food, if someone has Hep A, they didn't wash their hands from the bathroom, and now they're cooking your food, definitely is a way you could get it in a restaurant. So they always encourage them to wash their hands. And then any oral or anal sexual activity, obviously if they have that virus and you expose yourself to your partner in that way, you could get Hep A. So Hep A is the one that where you get exposed and you can give yourself that immunoglobulin. You go to the doctor. If you suspect that you've had sex with someone with Hep A or you've been exposed to it in a different country, they can give the immunoglobulin before you go to the country or potentially after if you've been exposed to it. Let's say you went on like a mission trip and you've been around a lot of poor, low-class people, potentially had to drink the water, say there was no other option, you had to do it. You would come back and get this immunoglobulin, and that potentially could help you from getting Hep A. But you would get your necessary vaccines before, so hopefully you would not even have this problem. Incubation period can be anywhere from 15 to 50 days. That's a long time. Okay, you may not remember what you did 50 days ago. Okay, so it can definitely be a burden for people that don't have good history taking when they had it. Hep B spread through, think about our seminal and blood. This is very common in nurses because they're going to get the poke in the skin. Most people would have the Hep B series, but I remember my friend in college, she got a bad dose of Hep B series, and she wasn't vaccinated. I mean, she was, but she did like a titer to see if she was actually covered, and it wasn't high enough. So she could potentially have gotten Hep B if she got needles stick in the hospital. Okay, so just because you've had it doesn't mean you're vaccinated against it. You could have got a bad batch. Blood transfusion, back in the day when they didn't do as good of surveillance of the blood that's being transmitted to people or for transfusions, before 1992, they potentially didn't do as good a job. And so we have to make sure that those people that have had blood transfusions are checked to make sure they don't have Hep B. Any type of blood that you're doing in the hospital, like dialysis, administering blood, you have a higher suspicion that they potentially could have it if they had someone with that Hep B virus. Obviously, when you're having a child, it can be transferred that way. And then also seminal fluid from sex. No known transmission by kissing. Okay, so don't think that you just kiss someone and you can get Hep B. It's more from potentially biting, which a lot of healthcare facility workers experience. Okay. The incubation period for here is 25 to 160 days. How many days? Is that 5 months? Yeah, it's like over 5 months. That's a long time that you could potentially get symptoms. So definitely 5 months ago, you may not know. I mean, you may have went to a different country, been exposed to this, got needle stick, poked. Some nurses have gotten poked and they don't go down to get checked. That's very naughty. I don't know why you would ever want to do that, but I've seen it and I can report it. I guess I should have reported it, but I was a new nurse and didn't know any better. Okay, if you get poked, you go down to the ED and get evaluated because you do not want to have Hep C in 6 months. Okay, what's that? Or AIDS, right? I know a lady that I felt so bad for her just recently. In the ICU, she got poked by someone that had Hep C, and she didn't know they had Hep C. She goes, "Oh, I just got a needle poke from bed 1," and I was like, "That person has Hep C," and she was like, her face went completely white, and I thought she was gonna puke. So she went down to ED, but she never had it. But they test right away. But remember, it can take 6 months, so she has to get tested again in 6 months. There is some chances you can. Yeah. There's like 15% chance, not very high, but that's one of the ones that are the worst. And usually Hep C is the highest risk for cirrhosis, is because it's the hardest to get rid of. But A, B, D, and E are very common to get rid of. But yes, her face was whiter than Emily's shirt, and I felt so bad for her. But she got tested the first time, obviously right away, to make sure you take your initial things, like your initial blood work, and then she has to come back in 6 months, which I don't think it ever happened. Like, it's very low to get exposed, but you never know. But the general symptoms, this is the same for all of them. So just because I'm putting them on each slide doesn't mean they're different. They're all the similar ones. The right upper quadrant pain, nausea, vomiting. They will have very dark urine, almost like tea color, and they can have joint pain and jaundice. Okay, obviously jaundice for hepatitis. Okay, it depends on how bad the actual hepatitis is, but their symptoms might be very mild or they can be very severe depending on how bad the virus is. Hep B is also another one besides Hep C that's very common in healthcare workers because of the exposure for blood products or potentially needle pokes. Most adults will recover from the Hep B virus. Like I said, Hep C is the only one that really has a problem with getting rid of it for chronic issues. But they can develop immunity. So once you've had Hep B, you will not get Hep B ever again. Okay, you have the antibodies if you get rid of it. Okay, so you have the good antibodies that will keep it. So almost getting it is kind of like getting a vaccine. If that makes sense, if it's a mild enough case. Okay, a small percentage of people will become carriers, and then obviously the best thing is to get vaccinated. We don't want to waste time. Make sure you're getting the Hep B series. Not that many people get Hep B series though. You'd be surprised how many places don't require it. I don't think my husband had it, and he went to college, but nursing school specifically made you get it because you're exposed to, needle pokes, needle stick. Get Hep B immune globulin injections. That's if you think you've been exposed to it, say in the hospital. They might potentially give you this to prevent it from occurring in your body. So those immunoglobulins are just the antibodies that they carry. All right, Hep C is probably going to be the most talked about, or the most, I'd say, important one of all of them, because that's the one that you can't actually get rid of unless you catch it very early. Hep C is going to have the highest risk for containing cirrhosis or progressing to cirrhosis. The way that you can get this problem is obviously the ones we talked about: blood, sharing needles, usually drug use is one of the common ones. A lot of people that come into the hospital that have Hep C are chronic drug users. Okay, not to stereotype, it is a fact. Okay, they do use the intravenous drug use. Unsanitary tattoo equipment, I've actually heard of this. Someone getting a tattoo and they got Hep C from it. Okay, happens a lot. Okay, gross. Healthcare workers, you might get Hep C and you might have it. I mean, it's something that it's a risk you do as a nurse or take. You've been exposed to different types of viruses, and some nurses actually do have it and they live with it, and they actually got it from someone in the hospital. Okay, something that happens quite frequently. Like I said, there's no vaccine available, but there is some research being done. I'm not going to have you know the treatment for Hep C because it's still kind of under testing. It's not FDA approved. Hep C is a leading indication of liver transplant. A lot of people that have Hep C will develop the end-stage liver failure and cirrhosis. They will need liver transplant. Incubation time could be up to 160 days. Again, a little over 5 months, long time. And like I was telling Brianna, 55% develop chronic hepatitis, meaning that they can't get rid of it, and the immunoglobulins are not effective to give to these people. Okay. Most people won't experience any symptoms until it's bad, until it's more severe. So even after a long time, potentially when you have cirrhosis, that might be the first signs that you have. And then you didn't even know you had hepatitis. How many people have you had sex with since then? Okay, so that's a big problem with incubation as well. These people might be having sex every night with someone different or every weekend. And how many people did you have sex with in 160 days? Okay, it could be a lot. Okay, so that's why we encourage these people to be very protective during sex.
This would be spread rates.
What's that?
This wouldn't be spread rates.
Yeah. Nope, blood and semen is the only way, or in vaginal. But sex. It's not like cystic fibrosis where you get new lungs, but you still have the underlying problem of cystic fibrosis. With liver disease, usually you can get the new liver and you are completely cured, essentially. There can be something circulating in the blood, like where you have chronic Hep C, or that might be a problem. With chronic Hep C, you could get a new liver, but you still have Hep C. So you might still have problems, but you might buy yourself 20 years. Yeah, so that's kind of like cystic fibrosis, but not in the advanced.
So how long do they usually live?
They usually live pretty normal lives. They might be cut short only because they're not stopping their bad habits, like drinking alcohol. But most of them live fairly fine lives, but they do get cirrhosis over time.
So if they get a liver transplant, they'll still, like, if they get, and they'll just get one time.
Yes, but like you said, if you have cirrhosis, you need a new liver, so your liver is potentially fixed, but you still have the underlying problem of Hep C. With cirrhosis, you can actually get the new liver and live a fine life or not have any type of shortness because that was their problem. The initial problem was their cirrhosis. As long as they're not actually having more drinking or more drug use, it should go away and it should stop over time or not actually get worse. With Hep C, you're always going to have circulating Hep C in your body. Just because you get rid of your liver doesn't necessarily mean that you're fixed.
Was it hard for them to get transplanted?
Yes, they do not like giving liver transplants to people with Hep C because they know that someone with cirrhosis or potentially may need it more and maybe taking care of it more would live a longer life. So yes, it is difficult. I think it's difficult to get any transplant, period. I mean, let alone having Hep C on top of it.
I think my patient mental health. I didn't even know.
I think a couple of you this semester, I said, I want to say Justine, because I remember that day, remember that guy in Med 6 in the unit, and I said, just to let you know, he has Hep C, and I don't know if you actually knew the severity of that.
He was Hep C.
Right. So it's standard precaution, you guys. It's not contact precautions. We don't put them in this bubble. You still wash your hands. I'm going to use my gloves every single time I go into that patient's room. But we had to how many times did we have to change his IV dressing that had blood? And we were exposed to so much of his bodily secretions that I was like, wash your hands. I was like, be very cautious in washing your hands because Now I have 2 people to worry about, and I think about it a lot more. So I always wondered that too when people are in the hospital, they take stuff home to their children. Just because you are exposed may not be affecting you because you have a good immune system, but you might take it home to your child that has a very low immune system. So you have to be really cautious and just use standard precautions. But yes, Hep C is very prevalent, you guys. I think I have someone every other week I'm in the hospital. Hep C is a lot. So it's not just one time in your life you'll have it. It happens a lot. So that's why I didn't know if you knew the severity of Hep C, but it's only standard precautions. We can't say, oh, you need to be quarantined because you have Hep C. You just have to be very clean. And obviously wear gloves a lot. Hep D, I would say this is probably the least, I wouldn't say important, but if you have Hep B, you can see a lot of variations of Hep D with that. And so if you get vaccinated against Hep B, you're vaccinated against Hep D. Even though there is no specific vaccine for Hep D, they have so much similarities in their antibodies that it can vaccinate against the Hep D portion. Okay. Like I said, you have to get Hep B before you can get Hep D. It's the same kind of similar virus. But I would say Hep D is probably the least one I want you to know for the exam. Okay. You can get something called interferon. It's a type of medication that helps with your immune system. That's one medication you can give to these people to help prevent any problems from occurring. Hep B is very similar to A. Remember the A and E, the vowels? Happens in the bowel. It's your GI system. So you can get it by kissing, oral, or anal. Okay. This is the one too where we think about different countries when you go over for like mission trips. You live in different countries, vacationing in Jamaica. These are things where you don't drink the water. That's why you don't do that, because they have such high risk for fecal matter and things that you can't break down. Okay. Think about in other countries, they might have heavy flooding. That's because all that bad water gets caught up and then can go on people's skin. They might potentially drink the water. Okay. It's a lot similar to Hep A. A lot of the symptoms are the same. GI symptoms, the right upper quadrant pain, very similar. Incubation period is up to 65 days. For the exam, I'm not going to say what is the incubation period for this hepatitis. I want you to know that just because you've been exposed doesn't mean you have symptoms of it. Okay? Know that it could take up to 5 months to have symptoms. There is no treatment for Hep E. It's just the immunoglobulin is not recommended. Remember, that's the medication we give to potential exposures. If they actually have it, they can actually make the symptoms less and then get rid of it faster. Preventing, we want to keep everything clean, avoiding the water, safe handling with your food. Make sure you're washing your hands very frequently. Okay? If you have Hep E, you can spread it to someone else. Okay, so when we're doing an assessment for hepatitis, and this is usually when they come into the hospital, we're going to give them a full assessment on what types of exposure they've had. So obviously we're going to ask about their sex history. This might be more in the clinic, not saying that we're going to ask admits with COPD, have you had sex in the last 30 days with someone with Hep C? We're not going to get that invasive, but we do want to know if they have liver problems. What is your exposure? What have you been exposed to? Do you live in close parameters with somebody else that might potentially have hepatitis? Have you had a recent tattoo done and it wasn't infected? Did you have a poor outcome? Injectable drug use. Are they IV drug users? You find a lot of people that will actually tell you in the hospital, and that can help us predict if they have any problems. Okay? If they traveled, another thing, have you traveled outside the United States in the last few months? And then we can test for all these drugs by diagnosing them with the types of labs. Okay, again, we went through all these changes for hepatitis, but these are things that you can see on assessment. They're all the same for all the hepatitises, okay? Just because you have A doesn't mean it differentiates between E, okay? So look for these on a complete assessment of hepatitis. It is dealing with the liver, so you are going to have that jaundice, and making sure that you're looking for any type of nausea, vomiting. They have a high risk for those. Psychosoc kind of relates back to your alcoholism patient and also how they got it. If they got it from a one-night stand or they got it from doing drugs, everyone comes in with a different story. We try not to be judgmental. We try to give them the care they deserve because they do deserve the care that they need. And we try not to focus on guilt or pointing fingers and saying that you shouldn't have done this or else that's the reason why you got hepatitis. Okay? Not the time and place, not going to fix anything. We always progress with the best attitude possible. We want to provide education to the family just in case the patient can't care for themselves and then that way they can understand, obviously with the patient's consent. If they don't want anyone to know they have Hep C, that's their right. We just encourage them to use safe sex practices, so they're not actually giving it to people for the sake of just giving it. Okay?
Like the age where you have to like trouble.
No, not as severe. No, because you can't. I mean, you can die of Hep C, but it's not like HIV where it's almost like a death sentence. But they can have Hep C, and we don't have to report it. We have to report it to our hospital just to put them on precaution, or like we put it in their chart. It's like a big red flag on their chart, but we don't do anything specific for it. It's just to notify the nursing staff to let them know. And then this is obviously a burden on finances. Think about how much some of these medications cost, especially the immunoglobulin or potentially that interferon that I talked about. Those are expensive meds. So now that they have all these other burdens financially, we're giving them meds that they potentially might not be able to afford. We have to be very cautious about what we're giving and getting social services involved to help with that. Okay. Presence of Hep A, B, and C is usually indicated by acute elevations in the following. So our liver function test will be elevated, makes sense because it's directly related to our liver. AST and ALT are very common ones that are direct functions of your liver. If you see any elevation of that, suspect something wrong with the liver. Okay? Bilirubin, if it's high, obviously directly related to how it's broken down from the liver. And then also it can be so high that it dumps it into the urine. So your UA can have positive bilirubin. Okay, we talked briefly about the antibodies that you potentially get with these types of hepatitis. If you have for Hep A, that's probably going to be your most common one that we're seeing antibodies with. But with Hep A, if you have IgM, and I changed this slide, I don't know if you noticed that, because it was so confusing, the first thing for Hep A, that I felt like it was, I don't know, it's on TigerNet now, but I felt like I read it like 4 times and like, they are not going to get this from studying. But if you have IgM in your body, it means that you do have the infection of hepatitis A. Okay? So if you see IgM, you suspect that you have some process of hepatitis, usually Hep A. Okay? That's all I want you to know for that. With IgG, that means you have developed the immunity. So after time, once you get better, you will never get Hep A again because you have the antibodies from Hep A. Okay? So IgG is what is developed in your body and stays in there for years. You do not get Hep A again. Okay? Hep B, whenever you are looking for Hep B for a person, you will take their lab or diagnostics. If they have a Hep B surface antigen located in their blood, you say, yep, they have Hep B. Okay? That's how they test for it. Simple as that. When I came to work here, I had to get a Hep B titer, and so they looked for my Hep B surface antigen to see if I had that immunity, and I did. Okay? Doesn't mean I have Hep B, it just means I have a small enough amount where it says that I'm immune to Hep B. Okay? If the person has a Hep B surface antigen, they are contagious, like if it's a very high amount. They do have that, and they are considered contagious enough to give it to someone. And it can persist for many months. So just because you have Hep B and you think you got rid of it, you could be contagious for some time. Remember from our HIV unit, the ELISA test? You guys remember that bedside test we did? And it would say, yes, you have HIV, no, you don't. They have something for Hep C, very similar to that, and it's done at the bedside. And they take their blood work, and they can actually tell them right there if they have Hep C. So very, very good bedside test, and it's fast. Okay. They also have another one called OraQuick, very similar to the ELISA. I'm just going to have you focus on ELISA because that's our primary diagnostic. And then your clear-cut way to know any type of hepatitis is a liver biopsy. You can do a lot of these that are preliminary. Remember with HIV, we might get a positive, but we have to do another test to make sure it's actual HIV. You know what I'm talking about? There's a ELISA and then there's another test to actually confirm. Western blot. Yep, Western blot. There you go. And that is more definitive. Okay, so if you get one positive, expect the next. Same for this. You might get positives on all these, and probably you do have hepatitis, but you have to get a liver biopsy to confirm. Okay, and that's why they're the least invasive to the most invasive. Okay. For hepatitis, there are some meds, but this is probably the primary things we're going to do. We need to make sure that they're resting their liver, because the more stressed it is, the worse the hepatitis gets. So we usually encourage bed rest, and for small periods of time. We don't like to see them for 6 months in bed, because that obviously causes more problems. But we don't want them doing their daily physical activities that they might do, that they have done in the past. We want to make sure that they're psychologically rested. We don't want to cause more stress on the body because they're stressed of why they have it. Diet, there's no specific diet. Remember with cirrhosis, we try to do less protein. Well, with this one, there's no specific thing, so don't get that messed up on the test. Okay. Comfort measures, we like to make sure that they're not having too much nausea and vomiting, so consider maybe medications to prevent that. And then if all else fails, we can do surgical management, but there's your answer, Katie. Liver transplant for clients with chronic hepatitis, especially for hep C, because they're the people that are going to have it forever. We can't actually get rid of hep A, B, D, and E. But with hep C, you're probably not going to get good outcomes. You're probably going to be last on the list. Someone with cirrhosis will probably get a liver before you would with hep C because of the potential risk of having it still. Okay, these people are really nauseous, so they're going to get antiemetics. Makes sense. Some of these are new medications for you guys. Zofran is the most common. The reason why we're using alternative medications to nausea instead of like Pompazine is because they're toxic on the liver. Think about how those medications are digested. A lot of them work on the liver. Even Zofran is a little skeptical on why to use it. We probably would use Zofran last because it's digested from the liver. Okay, but Zofran is such a good option because it's quick and it's actually quick to excrete. Okay, antivirals. This I'm just going to tell you right now. I'm not going to have you require this because a lot of these are controversial and they don't necessarily work. Okay. You're going to treat the symptoms of hepatitis and let the course lay out. Okay? It may take 6 months to get better, but we'll treat symptoms up until it's gone. It will go away unless it's hep C. They can do immunomodulators. That's specifically with interferon. This is the slide before that I was telling you about. I'm not going to have you memorize because a lot of these medications do have a lot of side effects, and they don't usually use them unless they're end stage. So for people with hep C, they might do something with interferon. That's the medication they go either sub-Q or IV, and that has a lot of side effects, a lot of cardiac side effects. So for these types of patients, if they're end-stage hep C, yes, we might try them, but we're not going to say, oh, you have hep C, let's go on to these medications. I know we're going kind of quickly, but I'm trying to get as much through here before you leave. Making sure that we're educating them on medications outside of the hospital. Remember, the liver digests a lot of medicines, so we don't want them saying, oh, I can take Tylenol, it's fine, I have a headache. We need to let them know that it's not okay to take over-the-counter unless the physician approves it. Because I would say a good 80% of meds are digested by the liver. Okay, so they have to be approved by the doctor. Obviously, abstaining from all alcohol. We want to encourage that cold turkey. So we will see withdrawals in a lot of patients. So looking at CWAS, making sure they're not withdrawing. Making sure good adequate rest and eating small frequent meals. This is just to help with their nausea. There's no specific reason for small meals. It's just so they don't puke up all the food they eat. Avoiding sexual intercourse until they have a negative hep C or hep virus. We don't want them having hep C and having a potential to go out and have sex with everyone to expose it. So we do encourage that. We can't monitor that. We can't go home with them on Friday night and say you can't do this. Okay, we have to trust that they're educated enough before they go home. And then standard precautions and universal precautions, making sure you don't share needles, don't share any type of equipment with anybody that potentially might have the virus. Washing hands is going to be your best preventative measure, and making sure that you're not exposing yourself to other people, like going home and obviously abstaining from friends. All right, questions, and then we'll let you go. When assessing a client with hep B, the nurse anticipates finding which of these? Hep B. You can remember. A lot of them have the same similar symptoms, so you should be okay to guess. C, D, and E? You are correct. Brown stool is from what? What makes you have brown stool? Bilirubin. Remember the breakdown of bilirubin, so that's not dealing directly with your hepatitis. Recent influenza infection. No, we have a hep B infection. The virus hep B. Okay. The physician performs a liver biopsy. During the first 24 hours following the biopsy, the nurse should especially observe for what? Hemorrhage. They have a high risk for bleeding. No NSAIDs, no anticoagulants until 7 days. What teaching does the home care nurse give the client and family to prevent the spread of hep C? How is hep C spread? tricky one. Hep C is semen and blood. Okay. With Hep C, think about when you brush your teeth. Have you ever made your gums bleed? That's why you can't do brushing teeth. It's not because they can't kiss each other. It's because when you brush your teeth, you have a potential to open up your gums, and that would cause the blood. Okay? So C is correct. And number B, you're probably wondering, well, that could be seminal fluid or their like secretions. But usually, if you think about it, public restrooms, you do it all the time. You share a bathroom with the entire world. Okay, I know it's gross, but how many people have Hep C in the world? Once you become a nurse, you get more and more exposed to this stuff. You start thinking how gross public restrooms really are. Like who's touched it, MRSA and C. diff and all sorts of stuff. Yeah, I'm not trying to scare you, I'm just trying to tell you. Which of the following situations would expose a nurse to Hep B? How is Hep B spread? Blood and semen. So D is going to be the correct answer. If you were in a patient's room, if you were giving an injection, it is not required you need gloves for an injection now. They've actually weaned that out. I still do it because I have to practice. But some people would potentially recap the needle after giving it to somebody. Okay, you're not supposed to do that. You're supposed to put it right in the sharps. They should. They really should. To prevent spread of Hep A virus, the nurse is especially careful when doing what? Remember, A and E is the bowel, spread through the bowel. So C, right? Empty the bedpan. All right, I will record the rest of that, and you guys have a wonderful spring break. I'll see you in 2 weeks.
Great. I need you to fill this out.
There's just 10 slides left. Actually, there's 8 because there's